A brief background from my end. As mentioned, my name is Tjasa Zajc. I'm the host of Faces of Digital Health. I'm a journalist by background, but this particular topic is specific for me because I'm also a chronic patient with experiences about problems with medication prescribing and an overdose, which happened to me while I was still a pediatric patient. And I worked as a healthcare journalist for several years, so I got a great insight into how doctors think, what's the doctor perspective on healthcare, what the challenges are from the doctor's perspective. And I felt that I really want to explore this a little bit closer than from the overview that you get as a journalist. So I transitioned to the healthcare IT industry, and I'm now a part of the team working on electronic prescribing at a healthcare IT company called Better. And that's basically where I got a little bit more insight into how challenges happened. And I started wondering if we have technology, and there's studies showing that technology helps with medication errors. To which extent is the state with medication errors better today than perhaps it was 10 or 20 years ago when To Err is Human was first published? And this is how this documentary came together. And I'm very happy to say that we've got great panelists that are now going to share their thoughts and reflections on the movie, because the whole topic and the movie itself is, of course, my interpretation and what I was able to put together as a story. But this story is only a very kind of a short insight into the complexity that surrounds medication management. So, just to start, I would like to share with you a statement from one of the panelists that unfortunately couldn't be with us here today. So, let me just try to do that. Advanced. Okay, just a second. Okay, so while I try to find that, perhaps we can use the time for another panelist to kick off the discussion. And I want to start with the first round of questions, and let's start with the patient perspective. So, Robert, welcome. We've got Robert Johnstone, who's the board member of the European Forum for Good Clinical Practice and the International Foundation for Integrated Care. And Robert, maybe you can start with kind of your side. You've been living with a chronic condition for several decades, and in the movie, in the end, Abdullah Al-Hassawi mentioned that we should include patients more in decision making. So can you tell us a little bit more about your background, and briefly, what do you see that has changed in terms of how involved are patients in decision making, and how are patients increasingly brave to even participate in decision making, since in the role of a patient one is vulnerable, and you might not want to oppose a doctor because you want to be in good relations with somebody that has your life in their hands. So Robert, please go ahead.
Okay, thank you very much indeed. I hope everybody can hear me adequately. You better send a little chat message, I guess, if there's any problems. Yes, I've lived for over 65 years with rheumatoid arthritis. And for the first 20 years of that, I was heavily dependent on medication. I was very fortunate that I had supportive parents who helped me through the experience and so on. But I was even more fortunate that I learned something which helped my self-empowerment before it was trendy to be an empowered patient. Before the words were even used, I think. When I was at university, I learned something called Transcendental Meditation, which I learned just to help me with the stress of my final exams. But in practice, it gave me the confidence to be a much better patient, to observe what was happening in my body, to modify my behavior and my medication, as I found I could do. Unfortunately, I got a lot of resistance from my rheumatologist when I went to see him. He said, I never gave you permission to do that with your medication. And I said, actually, you did. You said to me when I went to university, you're, quotes, an intelligent young man. I give you permission to modify your medication as you see fit. So I've a lot of experience of observing possibilities for good behavior and bad behavior with the medical profession. I would say one of the main issues was touched on in this program, and that is the attitudes of people in healthcare towards their patients, where even a good physician will listen to you, but maybe not respect what you're saying. And I these days I've worked a lot with patient organizations, and I really see the value of patient organizations for not only informing patients, not only working with physicians and hospital administrators to make services better for everybody, but actually in terms of helping to empower the patients, to give them the confidence to challenge their physicians in a constructive and hopefully friendly way. I take exactly the point that was made at the end there. Patients are often intimidated. They only go and see doctors when they really have to very often. They're maybe very ill, very tired, very intimidated. And the physicians and all the healthcare staff can do many, many good things to support them, to give them confidence, to encourage them to participate. That will help enable them to better adhere to whatever treatment regime is agreed, especially if they're involved in that process of choosing a regime. So I think that's all I should say now. I don't want to overuse my time, but I'm happy to take questions and interact more later on. Thank you.
Thank you, Robert. We are definitely going to have some time for Q&A. And so the next speaker is going to be Katrina Azer from New Zealand. She couldn't make it today, so we recorded her statement in advance, and I'm going to share that with you now. So she's going to do a short recap of kind of what touched her most in the movie, and continue with a little bit of her reflection. I hope
the movie Overdose highlighted a few important issues that disseminate throughout the healthcare system. So some of the issues that were highlighted were things like paternalism in healthcare, lack of patient voice, error in documentation, documenting errors as such, polypharmacy and non-adherence. So patients, forget to take their medications, and this could be due to access and affordability, so not being able to afford the cost of healthcare. The disconnect between the patients and the healthcare solutions that we provide. So while companies might come up with solutions like more apps, the continuous reminder can overwhelm the patients. Also, poor patient health literacy. There is lack of automation in terms of access to electronic health records, like Beta, for example, or limited data sharing between providers. Also, insufficient induction. So when we expose people to new systems, they need the training and the support when they're introduced. And lack of staff buy-in or clinician buy-in can lead to more adverse reactions, as was highlighted in the documentary. My background is I am a clinical pharmacist. I also sit on the Pharmacy Council of New Zealand board. So I have dealt with complaints against pharmacists. Some of them are due to medication-related errors. Some of them aren't. I'm also a graduate of the Australasian Institute of Clinical Governance. So clinical governance is a forte for me, and it is something that I'm incredibly passionate about. Medication-related errors have a few causes that could be mitigated. Essentially, the solutions lie, I think, from my point of view, in healthcare organizations adopting good clinical governance principles. So being accountable and responsible for the healthcare that's provided to our patients, and making patient care our top priority. I quite like a quote by Professor Liam Donaldson. So to err is human, to cover up is unforgivable, and to fail to learn is inexcusable. And I think one of the downsides that I've seen over the complaints that I've seen is people or clinicians who fail to take on board the responsibility of the error that was made, and develop processes and frameworks by which this error could be mitigated in the future.
So I'm just going to stop sharing now. And I think the quote from Katrina, which she mentioned, so to err is human, to cover up is unforgivable, and to fail to learn is inexcusable, is definitely something that we can all take home and think about. And going from that question, and given that Katrina mentioned the culture and kind of the leadership that's important when it comes to patient safety, I might want to turn over to Alexander, who is the CEO of the hospital in Kuwait. Alexander, you're also a nurse by background, so you've got two very interesting perspectives on management in the hospital and on the patient safety and medication management. How do you, as a CEO, see medication errors, and how do you try to minimize them as an executive in your institution?
Yeah, look, good evening. Thank you very much for having me. Let me not talk as a CEO for the moment. Let me talk as a nurse. And I want to catch on to something the previous speaker was saying, which is the accountability and responsibility that healthcare providers are not willing to take. It's true. Often that happens. At the same time, holding people accountable and responsible gets often misconstrued with not providing a just culture. Now I'm talking as a leader. Now this is a very fine line. When you hold people accountable and responsible, you may not be seen as holding them within the framework of a just culture. So you might be seen as introducing a blame culture. Yeah. A very fine line to walk that I've walked many a times, sometimes successful, sometimes unsuccessful. And so when you are enforcing holding people accountable and responsible, particularly if you have, we work here in the Middle East in a melting pot of societies that come from very power-fearing societies. If you hold them accountable and responsible, they may even hide more. So that is a very fine line to walk. And I've worked in Australia as well as a nurse. So I've worked in Europe, and I've seen this across the continuum. So it doesn't really, it is easy said and a lot harder done as a nurse and as a leader, I have to say that. Now, when it comes to the video, actually, very strikingly, in the very beginning, the paramedic who was talking about medication errors and everything, I have been a patient myself as an acute with a severe sepsis. And even though I was very sick, literally, I noticed that every single medication was delayed. Every single antibiotic was delayed more than 1 hour, which in itself is a sentinel event in a septic patient. And when the antibiotic was delivered, often the nurse was so rushed that when she primed the line, she wasted about 10-20% of the dose. So if you add all of this up, my hospitalization was probably prolonged massively. My whole course of illness was probably prolonged, and my risk of dying was actually very high. If you would have looked at, scoring tools, my risk of dying was very high. Now, I could clearly tell I was a weekend admission in this hospital, and the team was exceptionally stressed. So who to blame? And again, this comes back to this accountability, responsibility. As a leader, I have to say, particularly when it comes to integrating intelligent solutions, electronic medical records, and so forth, I'm often very frustrated across all systems that I've worked in with the healthcare regulator, because they have absolutely often no stake into regulating and managing how electronic medical records and solutions are being developed. So you have a whole bunch of people, sometimes with very good intentions and sometimes very commercially driven, developing solutions that are highly inadequate. And I challenge you to take electronic medical records, and you will find that probably most of them are struggling with the medication safety component. They get everything else done, but I bet you they struggle with a seamless transition from order to pharmacy review, to bringing it to the nurse, to administration. That's where most of these electronic medical records fail. And it's, as an administrator, that's very frustrating, because this is where the devil is in the detail.
Mm-hmm. Yeah, it's you kind of made me want to go to Jack-Li next, because so Jack, welcome. For everyone, Professor Yu-Chuan Jack-Li is a researcher of artificial intelligence. He's a dermatologist by background as an MD, and he's also the editor-in-chief of BMJ Health and Care Informatics. So, as a doctor, as a researcher of AI and decision support systems, how do you see that all the challenges that perhaps Alexander just mentioned could be mitigated with technology? So efficiency, prevention of mistakes. How can you combine all your roles in an opinion?
Yeah, So apparently, like many of the panelists already stated, medical errors is actually a systems problem. So, I mean, the whole healthcare system is still mostly uncoordinated. If we review the paper, the reports from the IOM back in the year 2000, which was 20 years ago, that started the whole patient safety movement. Many of the problems still persist that's mentioned in the reports. So it's still quite uncoordinated, and the jobs in the specialization is even more complex than 20 years ago. And the options, I was in an environment, I'm a dermatologist. So when I work in a remote island, it's very difficult for me to make medication error because they only has 4 medications for dermatology, right? So you pick one of the 4. How you cannot make a lot of errors. When I back to my hospital, I have like 200 drugs that I can choose from. So, and they all have different dosage and rules and all that. So we are putting healthcare professional and patients in a very complicated environment, and the environment is not getting simpler. It's getting more complicated over time because new technology, new drugs, new ways of treating patients. We are already reaching a tipping point that if we don't use a lot of information technology and AI, we are bound to make a lot of mistakes, right? For example, drug. There are so many different drug names for the same type of drugs, and there's no good regulation about the names. So I think in the initial several minutes of the movie, already look alike, sound alike was already mentioned, and there's a long list as described in the movie, and we're still making those mistakes every day, everywhere around the world. And why is it so hard even to prevent, a known problem that's been there for a very long time? I mean, that sounded like problem. It's because we are living in a very complicated, very complex environment, and doctors, when they're using computers, they have so many that can choose from, right? So every time I type A, I got 150 choice. I type B, I have 250 choices. So because in a very complex environment, we are bound to make mistakes. That back to the original question, how AI can help. AI can make things very simple, meaning we should take advantage of AI and IT development and make the environment simpler for our healthcare professionals. For example, if you prescribe medication, you're prescribing some medications, and you prescribe some medication, some drugs that cannot be explained by the diagnosis you're having here. You should be, reminded, or the list of drugs should be limited to what makes sense for this patient, right? Unless you click on something like expand the drug list. But I mean, we can use AI to make a growing, complicated healthcare environment simpler. And with a simpler environment, there are less mistakes. They're less prone to mistakes. One very serious lookalike, sound-alike incident in our country is penicillin. So a emergency doctor prescribed penicillin using the writing prescription. That was like 30 years ago. And the patient was injected with potassium. Okay, it's a high concentration potassium, and the patient heart stopped right away. And then the patient died. She was a very young, like 20-year-old girl. Okay, so I mean, the environment tends to be very complicated, very complex. So we need to make the environment simpler by taking advantage of information technology. I think this is, there are a lot of examples, but I'm trying to make it, simpler. So IT, if IT can help, it can help make our job easier, simpler, and reduce the burnout. As many of the panelists already implied, if you've been working for 48 hours, you're bound to make mistakes, any human. So we need to reduce burnout. We need to make the environment simpler. And by doing this, we will make the mistake. We'll make fewer mistakes and less error, right? So patient will be safer.
Thank you, Jack. Since you mentioned look-alike and sound-alike medications, in the movie, there's a few examples of medications that look very similar because the packaging is very similar or almost the same. There's the whole list of medications that can be written and can be misread because they look so similar. And at this point, I would like to give the word to Hicham, Naim. So Hicham is the global head of integrated and personalized patient care program and part of the digital advisory board at Takeda. He's a pharmacist by background, and I'm wondering, from a representative working in the pharma industry, how do you see these challenges with medication packaging? An overdose of the COVID vaccine happened because 6 doses were in one vial, and the nurse didn't notice that that vial wasn't diluted yet. So all these things are kind of a shocking examples, especially for the general public, and especially knowing that there are strict regulations in terms of what name can be registered when the pharma company introduces a new medication. So just, how can pharma contribute to increased medication safety in these aspects?
Hello, everyone. Can you hear me well? Perfect. First thing, thanks a lot, Chasa. That was a great movie. And personally, I learned a lot as a clinical pharmacist, but also as a patient. And a really big thank yous. I mean, before talking about look-alike, sound-alike problem and what pharma could do, I think it's important to say that no medicine is 100% safe. And it's responsible of everyone to make sure in this chain of event that whether it's a pharma, physician, pharmacist, or patient are aware about the drug, the effect. And I think one of the most important role of the pharma, besides making sure that the drug has the right risk and benefit profile, is to make sure that provide accurate, up-to-date, and clear information about the safe usage of those medicine. I think that's one of the most important things, and we need to emphasize that not only to physician, pharmacists, or nurses, but also to patient and caregiver. And I couldn't agree more with Robert in the beginning when he was talking about the fact that patients today are not necessarily listened to, and they are the most underutilized resource in healthcare. Now, talking about look-alike, sound-alike, it's a problem, and I'm talking not only as someone who is working for pharma, but also as a pharmacist. Because when I was working in a hospital, I have the same problem, and many times we were close to medical error. And I think pharma, if the regulation is not here, they can do at least two things. One is to make sure that when they select a drug name, that is not confused with existing drug names, especially if they are dangerous. The second element where I believe also there is a high risk of problem, and you have eloquently showed that today, is the packaging, the design of the packaging. It has to be clear, unique, and not be confused with others. Now, talking about packaging also, I think we talked a lot about drug safety, but mainly about medical error and overdosage. I think there's other element that we need to look at when we look to the packaging. It is an essential constituent of the medicine. It has to guarantee the stability and integrity of the drug. Because if it's not the case, this could be harmful to the patient also. It is also an essential source of information for patient and CP. There's another element that when we talk about packaging and the role of the pharma here is to make it as user-friendly, as easy to use as possible, because it can guarantee a proper use and promote compliance by patient. And I think example of what pharma can do, it's, for instance, for compliance to use a calendar blister. That's a simple one. But also it needs to guarantee safety. An example is, for instance, in hospital setting, it's the single dosage packaging, or in some case, safety cap for children. Now, there's one thing I want to close with that, because I think it's very important. You've mentioned that doctors spend on average 7 minutes per patient. Most of the doctors and nurses are experiencing today what neuroscientist Adam Ghazaleh said, it's a cognitive crisis. There's a lot of screen time, there's a lot of information overload, and this creates like a fatigue and stress. And if you look to the statistic, more than a third of physicians and nurses today are experiencing symptoms of burnout. And I think pharma has a role to reduce the stress level, at least in the packaging and naming.
Okay, thank you. So, given that you mentioned the burnout and the stress in the hospital environment, I hope Alexander can maybe later comment on how is it even possible, that doctors work such long hours. I never understood that as a patient, but before reaching that answer, I might want to go back to our final panelist. So I would like to also welcome Stefan Siekerski. He's also a nurse by background. He was an electronic prescribing project manager, and he currently works as the better delivery manager for the UK and Ireland. And in his past, he implemented 5 different electronic prescribing systems in 6 NHS trusts. So maybe Stefan, can you offer your comment as well in terms of how do you see the whole challenge, with mistakes? How can they be reduced with EPMA implementation? And we also saw that if there is no buy-in, so if the implementation is not properly done, then the hospital can end up in increase in adverse drug events.
Yes, thanks, Tiasha. So as you quite rightly mentioned, I've implemented quite a few different electronic prescribing systems, each of them different, in very different hospitals. And I think it was Alexander that mentioned, not every system is actually designed by a clinician for a clinician, and without that buy-in, I've learned over the years that it's not really the system that you're getting that's being implemented. It's the clinicians around it that can actually help develop that product. So if I was to take an example, quite a few years back, I joined a trust where a system had been implemented. The actual clinical needs hadn't been taken into account. It went into a theatre system, and within 2 or 3 hours, an incident had occurred, and the system got pulled out almost straight away. Everyone went back to paper because the system just was not fit. So from that point onwards, because I'd only just joined the team, I developed the solution around the clinical people. And so from now on, what I always say it's my biggest risk factor to any kind of project implementation is making sure you've got that clinical buy-in. I mean, your clinicians can help you with your formulary design, with order sets, with order sentences, and you can shape a system to your local policies, your national policies, or indeed medical guidelines. I mean, there was an example in the video about the purple pen being used to highlight some of the high-risk medications and some of the errors around that. Now, if you had clinical buy-in in a system at the point of before implementing, you can highlight these kind of medications within the system so that at the point of the prescriber then comes to a live system, you've got that there alerted to you. One of the things I did in the last project at Y Valley at the hospital around in the UK is there was building in actual tasks attributed to some medications. So for example, in the situation of the purple pen with gentamicin, as well as actually prescribing gentamicin, we were able to prescribe tasks associated to that at the same time. So pause, check levels, do a blood test, call on this. And these, whilst on a paper chart, you can probably highlight that somewhere, actually on the medication system, it was highlighted as an actual thing to do as part of the paper, as part of the digital chart. But I think this is pre-implementation. This is where we can help design and help combat some of the issues. I remember when I very first started, it was the biggest one was methotrexate. Methotrexate was quite a common issue. I know a lot of paper processes now within hospitals are robust enough to combat some of the overprescribing of them, of methotrexate, but it's the system itself that can prevent a prescriber going outside of protocol. It can prevent the wrong clinician from prescribing it that hasn't had the right training. Same with your intrathecal routes and other medications like that. So yeah, it's definitely worth having the clinician buy-in. But I think it probably expands on from that, is that you need to support post implementation. So I would say this needs to be a continuous support, and it's not always the support of changing the system or design the system. Sometimes it's support of the person. A couple of people have mentioned things like burnout. So one thing I've always done is had a telephone support line, a 24/7 phone number where nurses, doctors can ring up and have advice on the system. Now that advice, so in some hospitals you'll have a 24/7 pharmacy on-call cover, you might have a nursing cover, but sometimes the person on the end of the phone doesn't exactly know who to phone up. And if you've got an extra person, an extra set of ears to say, well, actually, I tell you what, this is actually a technical issue, we can help you. It's a clinical issue, phone your pharmacist, or hey, I can actually go onto your system and help you. It provides a support not just to the product but to the human being behind the product, and it just gives them that extra motivation that it's not just them there with the patient, you're there with the patient, you're there with them. And you know, I've had phone calls at 2 a.m. in the morning and they've apologized for waking me up, and I've said, that's what I'm here for. You know, you're tired, I'm tired, let's get through this together. You know, the patient comes first, not actually the product, not actually what we do in the process. So yeah, by having the support network, and that's the product isn't the system half the time. I believe the product is the support around it and the person within it.
You made a perfect introduction to kind of the second round of questions. So we mentioned a few challenges that are there, but I really want us to leave this discussion with perhaps solutions or maybe sharing of good practices. As Duncan Cripps mentioned in the movie, it's important to share also what's good so others can perhaps take on those practices. And just to start the second round, I'm going to again share with you a short statement from Katrina about, you know, just her thoughts where the problems are and what could be changed. So let's see that.
I think one of the speakers in the videos mentioned the blame culture, and that has been suggested as a contributor to high levels of medical errors. People make errors which leads to accidents. Accidents can lead to death. The standard solution is to blame people involved. If we find out who made the error and punish them, we solve the problem, right? No, it's wrong. The problem is seldom the fault of the individual. It is the fault of the system. So change the people without changing the system and the problem will continue. And this is actually a quote by Don Warman from Design of Everyday Things. So the message of the quote is stop blaming people for the errors that they make. Yes, there will be errors that will be individual fault, but this is seldom the case. It's often a case of the system that kind of perpetuates error. Finally, one of the important things that I would like to mention is design thinking. So ensuring the solutions that we put in place are user-friendly, both for the clinician and for the end user or the patient, through adopting design thinking concepts. So like things like empathy and understanding the needs of the patient as the stakeholder, assessing all sides of the problem that we're trying to address, and being solution-focused, experimenting and collaborating with all the parties involved, so the patient and the clinician. The problem is nowadays we just see all these apps and all these systems, and all you're doing is adding another pile to the patient's ever-existing pile of apps on their phones, and that can overwhelm the patient. So we need to make the solution unique and actually addressing a real unmet need for the patient. And I think that probably concludes my list of the possible solutions. And over and all, I think if there was one thing that I would add to that would be communication. So good communication between teams, whether it's through apps or through face-to-face communication, is important. That underpins every aspect of good healthcare provision. The problem is that healthcare systems, or we as healthcare providers, like to operate in silos, and individually. We don't think, who else is involved in this patient's care, and how can I work with them? How can I collaborate and integrate with other providers? We need to just work together. And like you were saying before, patients get prescribed a medication that people in other specialities have no idea about. Well, that is really poor patient care, because this is when adverse events tend to happen, is because there isn't a shared healthcare record between all providers. And I think, it's 21st century, and if there are health systems that don't have a tool like that, I think it's a disgrace, really, to be thinking that we're here and we don't have a healthcare record that is shared across disciplines by all providers. And then the patient, it's embarrassing when you have to ask the patient, what medications are you taking? Here we are in the 21st century where everything is available online, and you have to ask them, what medications are you taking? And you have to write it down. I just don't think that makes any sense. So yes, there is definitely room for improvement. Healthcare, medical errors are the responsibility of all healthcare providers. It is our responsibility, and we need to be accountable for reducing and mitigating errors. And we need to put patient-centric care, or patient and family-centric care at the heart of what we do. Then we will start to save money, because errors lead to more money expenditure, and we will provide effective and efficient care. So putting the patient at the heart of what we do is really, really important.
You need to unmute.
Oh, sorry about that again. Let's start with the second round of question. And at this stage, I would like to start with Hicham. As your role that's kind of looking at digital health solutions from the pharma perspective, where do you see most opportunities for improvement of medication-related patient safety, given your role, as I mentioned, as the global head of integrated and personalized patient care? What does pharma see in digital health?
Yeah, I mean, where to start? There's a lot of opportunities, but I think I want to highlight something that I heard about the previous panelist when she was talking about using design thinking, human-centered design. I was struck by a study where they looked to using eye pupil data, and they are registering digital fatigue. And what was striking is that over 1/3 of physicians in an ICU experienced fatigue in just the first minute of EHR use. And why I want to put that up front, I think technology cannot be the only solution, and it can be backfire, basically create more workload for physicians, more stress and more burnout. We're talking about the burnout. One of the problems with the burnout is not only about the long shift, it's because also of the different system they're using. They're not user friendly, and they create more stress for them. Now, talking about opportunities where pharma could contribute, and again contribute, because I don't think pharma has all the solutions. One could be, the easiest one is direct information. It's basically how to make the information about medication, the interaction, as easy as possible. Make it the access accurate, up to date when needed. I think that's very important. I mean, beside the classical leaflet and packaging and call center, today we are in 21st century. And if a doctor needs an information, he wants to have it now. And a couple of things that pharma is exploring is the simple one is the chat functionality. So you prevent this wait line on those call center. But like what we are currently exploring, smart agent, where you have an AI behind that, because the value of using AI here is you reduce the wait time, but also you reduce human error. Another example of technology that pharma is exploring, my company is exploring, is using smart packaging. We're using technology like NFC or just a pure QR code or a RFID, where basically using your smartphone, you can access all the information about this product. And this also can limit the misusage of this product, medical error, but also sometimes we don't talk about that the counterfeit. That could be also a source of harm for patient. The second area where I believe pharma could contribute is pharmacovigilance, is how to make as easy as possible the reporting and monitoring of adverse event and medication error, because this can improve transparency and it ultimately can avoid future adverse event and medication error. The third one, I mean, they are more expert than me here. It's clinical decision support. I mean, there are tools today, but they're not yet ready. And Mark did it perfectly eloquently when he was talking about basically having a long list of medication. It doesn't make sense to have the full list because you put an A. It has to be linked, it has to be contextual, linked to the patient characteristic, the diagnosis, and so on. And that also could help analyze the drug interaction, not only within the prescription, but also looking at patient history. I live in Switzerland, and it's one of the most advanced healthcare system. And when I was in University Hospital and I need to come back to my family doctor, I had to take my data on a CD, literally, because there is not one system that talk to each other. And finally, I think, and this is a bit tricky part, is how can you leverage digital tool to do disease management and help patient without, and it was well said during the video, without reminding patient every time, every day that they are sick. And one of the elements is adherence. And here I'm more talking about not the persistence, being compliant over time, but the element of concordance, you know, how to make sure that patients are taking medication as prescribed, dosing, frequency, interaction. That's a very important and simple tools that we have developed. One, it's an AR tool, augmented reality tool, that basically help patient when they use their own smartphone, learn how to self-inject themselves, whether it's patient or caregiver. Another, if I stay just in the injection, we developed a tool called injection tracker, because sometimes when you do a subcute, you don't want patient to inject themselves all the time in the same body part. So this tool can help them basically alternate places for injection. And those are just simple tools that can basically reduce the burden of the disease on the patient. And like I said, again, technology is not all the solution. And I think it's a system problem. And needs to be solved by not only pharma, by multiple stakeholders.
Thank you, Hicham. You definitely highlighted a lot of aspects. And given your mention about AI, which was also talked about in the movie, and explained that, you know, there's two types of news when it comes to AI in healthcare. So one is AI is going to solve everything. And the second one is, oh my God, we got an AI system. It got one thing wrong. So there's a difference between what we kind of see as normal when humans make mistakes, but when it comes to machines, we expect 100% accuracy. So at this point, I would like to give the word to Jack-Li, who is the researcher of AI in medicine. And journalists always have one question, and that is, when are we going to see that in practice? You know, so I wonder from your perspective, and just make sure that you unmute yourself when you start talking, is how do you see what kind of systems will be in place in 5 to 10 years, not just on retrospective data, but in real time, without the concept drift, so algorithms losing their accuracy over time?
Okay. Well, it could be a 60-minute lecture, but I'll try to make it 60 seconds. But that's why I always put AI and IT together when we're talking about patient safety and medical errors, because whatever works, you know, we should apply them right away as soon as we can. There are medical error problems that can be solved without AI, just by simple IT, right? For example, maximum daily dosage should be applied to all the drug used for children, and maybe also seniors, because you don't need AI to do that, right? It's just simple IT, just simple rules. But there are also problems or errors that cannot be captured or prevent by simple AI, by simple IT. You really need AI to do it. And there are many different levels of AI. So when I say you need advanced AI to do it, I am mostly referring to machine learning based AI that deal with complex situation. For example, if we prescribe a drug that's a sound alike, look alike, but it's not the right drug, it will be very difficult to use conventional IT to stop that, because there are many factors you have to check to know whether this is a intentional prescription and off-label use, or this is the wrong drug, right? That's the time that AI could come into play and really recommend the right drug. Because when you're in a very complex situation that there may be hundreds or thousands of variables that you have to consider all at once, then traditional IT would not work very well. And of course, human doesn't work that way. So human only consider like 7 variables, and that's probably maximum for most humans. Very smart doctors could probably consider 12 variables, but no one can look at hundreds of variables, thousands of variables. So that's when AI comes in. So in the next, I'm not sure about 5-10 years, but if 3 to 5 years, I would say we really can use AI in terms of making the choices simpler, because they are, as I just described in our first part of the panel, the environment is so complex. And I'm a doctor, then I go to the same hospital every day, and I still sometimes get surprised by the drugs we have, by the procedures that's available, and by the choice in the lab and exam that was there, and I did not even notice. So it's those complexity that collectively contribute to a lot of errors. So what AI can do is it can make the environment easier. So without further action, it will make your choices simpler, to kind of a confined environment. Unless you want to go out of your comfort zone, you can click something and you go out. But usually, so AI could put you in a safe zone that, it's harder to make mistakes, right? So this is, of course, just the general idea, but as I can see, it can be applied in prescribing drugs, procedures, lab exams. It can be applied to, even surgical decisions and ICU, many ICU decisions, because we just don't need, we don't need everything, every possible prescribing, items at our fingertip. We don't need that. All we need is what we are comfortable with, right? So Methotrexate, the drug, was mentioned a while ago by one of the panelists. As a dermatologist, I prescribe Methotrexate at a very low dose, like 2.5 milligram, to a patient with psoriasis. But one day, our hospital has a different Methotrexate that's 25 milligram. And I didn't see it. I just saw Methotrexate, and I picked Methotrexate, and I end up prescribing 25 milligram Methotrexate to my patient. It's the nurse that recognized, Dr. Lee, you sure you want to prescribe 25 milligram? I said, no. We, as a dermatologist, we never prescribe 25 milligram Methotrexate because that's for breast cancer. Every time we only prescribe 2.5 milligram Methotrexate. So the system, the AI in the background should know that and prevent me from seeing the 25 milligram Methotrexate, right? But in order to perform this task, the AI system needs to know a lot of variables in order to be performing a task at the right and without a lot of inconvenience, right? So I think all in all, there are just many possible ways, but overall, I think AI could provide a simpler and less error-prone. I'm not sure it's error-proof, but at least it's error-less, environment. So humans are less easier to make a mistake.
Thank you, Jack. And the situation that you mentioned, so AI preventing doctors from making an error, that's kind of the dream, or not even a dream, an expectation of clinicians working in the clinical practice. And unfortunately, they're often kind of disappointed because at the moment, the systems that are used are basically what I would say a healthcare IT solutions 1.0, and we want to have 4.0. So definitely I want to go to Alexander next. As the CEO of a hospital, do you often get approached by startups or solutions that are claiming that they can support clinicians, and how are you approaching the aspect of adding technology to improve medication safety? Is there any plans that you can share with us in terms of how do you see most progress can be made in a short time?
Yeah, I get quite often. I probably just deleted 3 emails today from companies that promise the world in every way. I want to say I'm a great fan of AI and machine learning, and I've seen its power if used sensibly. So, for instance, combining coding data with pathways, and then using the same for looking at deviation and medication prescription practices and so forth. That's when I think this is where the power comes in. I think there's huge gain in that. I personally feel I'm still in my infancy and understanding it, which actually leads me to where I think the first solution should come in. The first solution should come in how healthcare is educated these days. I don't think our healthcare education, medically, nursing, allied health, I don't see it. I don't see people, I don't see new students come through with a better understanding of patient safety, medication safety, and then like contemporary solutions. I think healthcare education systems, in my opinion, are failing. My oldest is a paramedic, about 2 years out. I don't think he had much learning in the university based on this, and he works now in a very mature, very large metropolitan healthcare system that you would think has a very sophisticated support system, and it does not. It's actually abysmal. It's ridiculous. So I think the first solution needs to come in healthcare education. Look, I've not been attending sort of an undergraduate course recently, but I would be surprised if AI and these topics are on the agenda. My feeling is you have to go to postgraduate courses, and then even then you have to attend courses that are probably geared in this direction. So it's very interest driven. If you have an interested, you might like Dr. Lee has an interest in it, but I think maybe the average doctor does not. My doctors, when I speak to them about decision support system, some say, well, let's talk in the sky. Some say, oh, another system you want to put on me, or another restriction you want to put on me. So as many speakers say, unless this is helpful, it actually becomes more dangerous. And the whole thing about alert fatigue or overriding alerts and all of this. So in a previous organization, we were implementing a decision support tool, but all clinicians asked immediately for, well, we need to be able to override all of this. So it becomes a white elephant then, right? You have it, but then you don't have it. It becomes sort of a maybe safety feature. The very good ones use it, or not at all. It's not clear to me. When it comes to a best practice example, and I think I've mentioned it to you, it's like I've heard early on about medication reconciliation and how ridiculous it is in this time and age that you have to ask the patient and then write it all down and then you compare it with the previous list. So in a previous healthcare system, it's really one of the few systems that I've seen where they have developed a sort of a health exchange information system where all EMRs feed into the same database, and between private and government hospitals, clinics and tertiary, whatever system you're in, you can see what was ordered, what was prescribed, x-rays and so forth. So I think that's AI needs to come in, but I think there are many low-tech solutions. Starts with education, and then using the things that we have a lot better. And I think one thing that needs to stop is the medley of electronic medical records that are out there. I think not sure who can step in and write a good, great standard about it and regulate it, but somehow those, and you don't want to stifle innovation, but I think it becomes a zoo of medical records, and then it's very cost driven, right? Like what you can afford as an organization. And I think, as Stephen said, many systems are cumbersome. Clinicians don't like them, and then some systems they're luring organizations in and clinicians and saying everything can be modified. But the systems we work in, they're made by humans. So often you find an acceptable medical record is then modified so much by the clinicians and the end users that it actually replicates the same system and the same errors. So all you did is you digitalized a bad system. And so this, again, is the fine line between saying to clinicians, here's what we want you to use because this is safe, versus the clinician feeling he has no room to move. Again, many fine lines. Yeah, give us another 20 years, I say, we will see the solution, maybe.
Not very optimistic for sure, but you mentioned one point, and without saying it, you were basically talking about the most hated word in healthcare, and that is interoperability among the systems. And I would like to, at this point, ask Stefan, who is a representative of a healthcare IT vendor offering an electronic prescribing system, how do you see, this whole issue of siloed systems, which are still a reality? And can we encourage vendors to talk more among each other to create kind of bridges so the systems will talk to each other and help the end users?
Yes, thanks for that again. Sorry, you may have seen me moving my camera. I was trying to plug my laptop in. I think my battery's about to go. But yeah, from how do we see these systems? I mean, I think a few people have picked up on the more in that, the Katrina on the panel video was mentioning about how many apps people are having, how many different things that people are using. Hicham, you mentioned about, a lot of not being very user friendly, and this is a big problem, and it creates more issues. But I think what we can do in the future is, and it's been picked up in the chat with Lee and Jack mentioned about medicines reconciliation, is by having a lot more data connectivity. So building interoperability, it's the big buzzword in healthcare at the moment, but it's also a word that is something that's working in the NHS. I can give an example. I'm currently working on a current couple of projects where we're trying to link in. What we've got is the EPS, which is a system where the GP will order medication and it will come out at the pharmacist. So we're able to link into that with hospital systems and grab that medication and display it visually as to a clinician in the hospital. This is the medication from a GP. People have mentioned that, sometimes a list of medication contextually isn't great if you don't have the context behind it. But these are where we can start building on the interoperability of different healthcare systems. So looking at not just the EPS and GP Connect, but looking at the inter-hospital systems. So all of your old EHRs or the siloed systems that are out there, if you can have a platform to view all the information that you need at the point of prescribing, albeit that information may have come from a GP, it may have come from the patients themselves. It's good to have that information there. Some of the other things that we do, and I've mentioned, people have talked about patients having access to their own information. So we are now looking at building apps where patients themselves can see their own medication. On my phone, I do have a link to the GP that I can see my medication on now. It's not great, it's not structured, it's not usable. It wouldn't tell me at the moment what I'm discharged on, but this is where this information can start being built and being developed. I think Yeah, so with interoperability, we don't just have to talk about the wider picture of talking to different healthcare providers, of having regional platforms. But there was a case on the video, I think it was the second person on your video, that was talking about the incident where he was about to be administered medication and he pushed it away. Now, interoperability here would work in that we are developing ways of looking into pulling information out automatically from blood pressure machines, heart rate monitors, and those kind of things would be able to put the information that the prescriber and the administrator at the time saying, so this patient has got this medication prescribed, and then the alert might come up, or might, if we get to the AI stage of things, not even be able to prescribe or administer that kind of medication. I know now we're looking at looking into medication cabinets. So for closed loop, when that comes along, we can start looking at how medications themselves can be dispensed based on the person that's been prescribed. So there's a lot going on. And I remember thinking 13 years ago when I very first used an electronic prescribing system, how advanced it was. And I was thinking, well, this is so much better than paper. But 13 years down the line, I'm still thinking to myself, there is a lot more we can do. There is still so much more we can do. And we've got to keep developing. We've got to keep pushing on and thinking. And groups like this, I think, is fantastic, because there's so many ideas and so many different people working on this, because it's not just a future for the vendors like where I'm working now, but it's really the future for our patients. As I say, I'm a nurse by background and I still practice as a nurse, and fundamentally for me it's the patient safety. But I hope that answers your question. Sorry, my battery is flickering now, sorry.
No problem, Stefan. I do want to end the panel with the voice of the patient. So I would like to ask Robert, for his final thoughts about, we constantly talk about patients and putting patients in the center. So let's hear from a representative of the patients about what patients need most, and perhaps how can patients take a more active role in shared decision making. I thought that was one very powerful message, again, from the movie, from Abdullah Al-Hasabi, when he said that, we need to empower patients better. And it's really hard to empower patients when they have 15 to 20 drugs prescribed. It's impossible. So perhaps just a note from the patient perspective, from my perspective, I think clinicians will always need to, in the reconciliation process, regardless of the list that they have in front of them, ask the patient what medications they're taking, because patients might not be taking medications that are prescribed by choice, because it's just too difficult. And it's a whole broad topic on its own, so maybe a topic for the next documentary. But for now, Robert, please, for some final thoughts. And just unmute yourself, please.
Good. Yes, thank you very much for the opportunity to take part in this. I think what I would like to say as a sort of summary point really has already been said in the video, but I just want to emphasize it, that patients are probably the most valuable and most underutilized resource in the healthcare system. We don't want to be seen, especially those of us with chronic problems, we have to keep going back to doctors. We don't want to be seen as the problem. We want to be seen as part of the solution. And with appropriate training and support from well-funded patient organizations, patients can be good patients, asking high-quality questions, being active and positive participants in a decision-making process. And, we're very happy to work with everybody. It's for our own good, but they need to listen to us and respect what we say and involve us in processes, whether we're talking about the prescriber or whether we're talking about the pharmacist, whether we're talking about the design of the packaging and the leafleting. So really good communication between the patient and any sort of healthcare professional with a willingness to involve us in good communication, will help that patient buy-in, will facilitate that adherence, will help the systems, whether they're AI or manual systems, to develop learning about what works and what doesn't work. I also would like to pick up on a point that was mentioned earlier about system-wide change. It's not just the healthcare professionals or the patients who need to change. It was mentioned about in Kuwait, some things are quite down motivated, perhaps should we say. We do what people say rather than actively participate. I can also give an example from Qatar, where an expat was suffering some flu, an expat not working in healthcare, working just generally in the system building or something like that. And in the UK, if you had flu, you would just take a few days off work, and then self-medicate with something you buy from the chemist if necessary. This particular person had, by law, because he was an expat, he had to drive across the city, even though he was unwell, in rush hour, to go to a hospital, wait several hours to see a doctor, be prescribed a medication, which was an antibiotic, and he knew his own system well enough to know that an antibiotic was not only unnecessary, but was actually not a good thing to take. So he went home, didn't take them. 2 or 3 days later, came back to work. Now, he only had to do that because that's what the system militated. That's what the system demanded. He couldn't get his salary. He would lose his job if he didn't follow that system. Now, that's frankly stupid. That's over prescribing somebody's activity when he was the sort of person who could just make a decision for himself and get better in his own time. So there's lots of examples like that as well. But one thing I think finally I'd like to say is that I've really enjoyed this interaction. I hope others have well. And I really would value the opportunity to spend more time together and discuss these things in more detail. Thank you.
Thank you, Robert. And that concludes our panel. We already spent an hour on it. It's getting a little bit late, but if anyone wants to add anything, please either raise your hand or just unmute yourself. That also goes for everyone in the audience. I would like to thank the speakers from the movie that also joined this discussion. It's great to see you. And so does anyone want to add anything? Alexander, go ahead.
Just, because obviously I've been very critical, right? I have a positive outlook on where we're heading. I'm just thinking that sometimes we jump the gun a little bit and we go with, we're thinking AI when we have a lot of low-tech solutions at hand and so forth. So I have a very positive outlook. I just think healthcare often is not critical enough with itself. So I don't want to make that same mistake. And I very much belong to the system. So we're fixing it from within. So very much enjoyed it. Really well done. Thank you.
Thank you. Anyone else? Jack, go ahead.
Just one quick comment. I've been saying that we should turn our healthcare system or the hospital system from a cost capture system to a really health care delivery system. But actually, if we have AI that help us do all the cost capture, then we can have more time to make it a care delivery system, right? So I think there's no conflict into what AI can help in terms of cost capturing or care delivery, and as well as medication error reducing.
I agree with you, Mark. Maybe I will complement this with say that it's artificial intelligence with human empathy, and empathy toward patient, but empathy also toward healthcare professionals.
Definitely much needed, especially in the current state of healthcare IT. So at this point, I would like to thank everyone for taking the time to, first of all, see the movie, join this panel. This will be published on the Faces of Digital Health YouTube channel and on the podcast. So everyone that couldn't join us today live can have a look at this, listen to this. I will add links to the documentary also to the show notes. So thank you again, everyone, and I hope we can continue this discussion to just impact the patient safety further. And I think everyone can take something from it. So I'm hoping that patients will consider them as the participants in the healthcare systems that have the power and that can impact their care, but they do have to take not interest but responsibility, so not just expect that everything is going to be decided for them. Family can have an immense impact when you're feeling unwell, and perhaps others have a better understanding about making decisions. And when it comes to healthcare professionals, it's very difficult to kind of navigate between the empathy towards the patients and the volume of the patients that you see, and to still stay sane and not get overwhelmed by all the pain and the suffering that you see. So again, a very complex topic, but if all the stakeholders contribute a little, we can already achieve a lot. So thank you again, and see you at the next opportunity. And I will end the meeting. Thank you.